a number of folks already joining us, so I might as well go ahead and get started. So I'd just like to first acknowledge that we are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and is a provincial research institute committed to improving the health outcomes of women, including those across the 2SL LGBTQIA+ spectrum. We recognize our responsibility in the collective efforts towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And we would encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada Calls to Action and the In Plain Sight report, and reflect on the ways that we can incorporate the recommendations into our own work. And as we gather in spaces together, we encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. So I'm very pleased to be able to introduce our group of round speakers for today. I'll start with Lori. Dr. Lori Brotto is a professor of obstetrics and gynecology at UBC and a Canada Research Chair in Women's Sexual Health, who pioneers accessible treatments for prevalent sexual concerns, emphasizing equity and leveraging digital health tech. She, of course, is also the executive director of the WHRI and has a media presence including Netflix, The Principles of Pleasure, CBC's Gems, The Big Sex Talk, and has authored a few books on mindfulness, and complements her active role as a registered psychologist in BC with that work. Advocating for women's leadership, she mentors aspiring STEM professionals and believes fervently in the power of knowledge mobilization. Dr. Marina Adshade is a faculty member at the Vancouver School of Economics at the University of BC. She is one of Canada's foremost economic experts on the role of women in society and a major advocate for inclusive cultural reform with the goal of increasing safety, competitiveness, and leadership. Her unique approach to research applies a mix of economic, sociological, and biological and psychological theories and evidence to a wide range of social issues. She is a sought-after speaker, writer, and social commentator, and has published over 60 opinion pieces and feature articles in the Wall Street Journal, the Sunday Times, the Daily Mail, the Globe and Mail, Time Magazine, Psychology Today, the Daily Beast, and BuzzFeed. And Dr. Kerstin Gustafson did her undergraduate and master's degrees in molecular genetics at the University of Toronto. She then went to UBC Medical School and did her residency in OB/GYN at the University of Alberta. She's been practicing in BC since 2006. Her main practice interests are in menopause and aging, and she's been an osteoporosis consultant since 2007 and completed her NAMS certification in 2010. So with that, I will hand it over to our speakers.
Thanks so much, Catherine. Good morning, everyone. Great to have you all here today. We're very, very excited to, on behalf of our much larger HERC team, present some of the findings and recommendations from our HERC study. Catherine, thanks for the very lovely land acknowledgement at the beginning. And I want to acknowledge that today I'm coming to you from my home, which is situated on the Quikwetlam First Nation, which lies within the shared territories of the Tsleil-Waututh, Katsi, Musqueam, Quakwat, Squamish, and Stolo nations. And as always, we give gratitude to the original caretakers of these lands. So I'm just going to open my slides, and Catherine, you can let me know if my slides are in good view.
Looks awesome.
Okay, great. We refer to this as the HERC study, Health and Economics Research on Midlife Women in BC, and a nod to Nicole Presley, who's the queen of acronyms in helping us come up with the name. This is going to be a team presentation. I'll start by giving you an overview of the work that we did and present some of the cross-sectional data. I'll then pass it over to Dr. Adshade, who will do a much deeper dive into some of the impacts on the workplace setting. And then finally, Dr. Gustafson, who will talk about why these findings matter and the implications for sort of the bigger picture of health and knowledge and well-being and treatment when it comes to midlife women. So I think we can all appreciate that menopause is definitely having a moment. You'd be hard-pressed to turn on the TV during the daytime or listen to a podcast or scroll through your social feeds without coming across some mention or even some in-depth discussion of menopause. Here's just a snapshot from literally the last month of 2024 to see some of the high-profile pieces talking about menopause. In fact, in 2024, the #1 most listened to podcast in the entire world was a conversation focused on menopause with podcast host Mel Robbins. Now, it wasn't always that way. When we go back and we look at sort of the history of menopause research, it sort of had some ebbs and flows in how much we have had some recognition, public discussion, and even attention to menopause. And I'm going to spend just a minute or two talking about the Women's Health Initiative because for many of us in the field, it really marked a change in our sort of understanding of the best way of managing midlife women who experience menopausal symptoms. And so for those of you who've never heard of the WHI, it was a series of clinical studies, and it was initiated by the US National Institutes of Health in 1991. And the goal was to address major health issues causing morbidity and mortality in postmenopausal women. And it really consisted of 3 related but distinct clinical trials and an observational study. And in particular, the randomized controlled trials were designed and funded that addressed cardiovascular disease, cancer, and osteoporosis. The largest women's health study of its time, and many of you have heard us talk about the dire state of inclusion of women in clinical trials. Well, the WHI really turned that. In fact, it recruited and enrolled more than 160,000 postmenopausal women aged 50 to 79 over 15 years, making it one of the largest prevention studies of its kind. The budget was well over $620 million. And so the design of the hormone therapy trial was approached with the hypothesis that estrogen therapy would result in a decrease in coronary heart disease and osteoporosis-related fractures. And as such, the primary outcome of interest was coronary heart disease, as this is a major, major cause of morbidity and mortality. And in fact, one of the top reasons why women are placed into nursing homes. As the trial progressed, you can see the timeline at the bottom there. Due to the concern over the relationship between hormone therapy and elevated breast cancer risk, breast cancer was also selected as a major primary adverse outcome. So the hormone therapy component was originally designed to include a follow-up period of 9 years. However, the interim monitoring of the combined estrogen-progestin treatment group indicated an increased risk of breast cancer, coronary heart disease, stroke, and pulmonary embolism, which outweighed the evidence indicating a benefit of preventing colorectal cancer and fractures. And so as a consequence of that, you can see down here in 2002, the hormone therapy pills were stopped with an average follow-up period of only 5.5 years. So as a consequence of those interim analyses and findings from the WHI, which indicated that the incurred risks of hormones outweighed the benefits, the study authors recommended that hormone therapy not be prescribed for the purpose of chronic disease prevention in postmenopausal women. Here's a heading from the New York Times, and I remember this well because I had just started my residency. It was actually the first day of my psychology residency at the University of Washington, and the entire day was sort of sidelined and devoted to the discussion of this New York Times piece and then the subsequent diving into the paper and the study itself. So the subheading for this New York Times article was "Hormone Replacement Therapy is Called into Doubt." But an accurate subheading probably would have been "Hormone replacement for disease prevention is called into doubt." And so the message somehow became that no one should ever take hormones, as opposed to a much more accurate conclusion, which was Premarin plus MPA isn't effective for disease prevention. So as a result of this, what happened was that we saw hundreds of thousands of women who had been using hormone therapy, menopausal hormone therapy, stop their hormones. And it really ushered in, for a few decades after that, a lot of concern, both among the public, but especially among healthcare providers, about the potential harms of menopause hormone therapy. Now, I'm not going to say anything more about the WHI, but for those of you who are interested, you can go back and watch one of our opening keynote presentations from the WHRI symposium from 2024, where the keynotes discussed, the WHI was not a bad study. It gets criticized for being a terrible study. It was, again, the largest randomized trial of women, extremely well designed, multi-site. The problem was in the interpretation and the sort of media overblow of the findings that led to some misleading conclusions. So what that really led to was a few decades of, a lot of silence, and also a lot of women who were having very bothersome symptoms related to the perimenopausal transition and postmenopause, who had those symptoms largely untreated. This was a report that was commissioned by Sun Life, led by Menopause Foundation of Canada, published last year. And what they found was that the unmanaged symptoms of menopause cost the Canadian economy $3.5 billion per year. So that included $237 million in lost productivity, $540,000 days lost of work, and $3.3 billion in lost income due to reduction in hours and or pay, leaving the workforce altogether. Dr. Adshade is going to share some of our own data that speak to this, but the conclusion was that a lot of these individuals were having symptoms that probably could have been managed by menopausal hormone therapy or other evidence-based therapy. And because they weren't having their symptoms managed, it had this very dire impact on the workplace, but also on their quality of life. So that's a pendulum on the bottom. And what we're seeing now is a resurgence in interest in menopause education, menopause research, and just an upsurge in the number of healthcare providers who want to become more knowledgeable and trained in the area of menopause care. So in BC, we know there are 875,000 women who are aged 40 to 65 who are in that age range of menopause, which, by the way, menopause is a single day. I know that sometimes we use the term interchangeably referring to a phase, but menopause is a single day that represents the day after 12 consecutive months of having no period. And that's for the individual who has a natural menopause. Of course, for someone who has a surgical menopause, iatrogenic menopause, then that would be a much more abrupt shift from the perimenopause, which is the phase of life leading up to that single day. And then everything after that single day for the next, let's say, 30 or so years of one's life, if we look at average life expectancy, referred to as the postmenopause. So we know that although up to 80% of women, based on the large population-based studies, experience bothersome symptoms in the perimenopause, and even though we tend to think about hot flashes and night sweats exclusively, there's actually up to 30 different symptoms that women and gender diverse people can experience during the up to 10 years of the perimenopause. And some of those symptoms get better during the postmenopause, but some of those symptoms actually worsen. Symptoms of menopause can impact daily activities, such as work and caregiving and mental well-being, and those symptoms often interact with one another, and that really set the stage for our interest in the HERC study. We know that research is absolutely needed to combat misinformation, and especially to turn the pendulum once again around what is the accurate information about women's symptoms, their level of tolerance of symptoms, and the evidence-based treatments. And this takes us to the HERC study. So this is our team. Hopefully some of them are on the line today. Some of them I'm co-presenting with Dr. Adshade and Dr. Gustafson. And we began to have conversations about this about 1.5 to 2 years ago, about the gap in knowledge when it comes to midlife women's health. And this sort of coincided also with the development led by BC Women's Hospital and funded by BC Women's Health Foundation around the creation of a new program focused on supporting midlife women with complex menopause symptoms. And so in discussion, we assembled a team who are presented here, and we were comprised of academic researchers, clinicians, individuals with lived experience of menopause and associated health issues, to come together and to commit to addressing this gap through research. I'm extremely grateful to every single member of the team. And I want to just give a particular shout out to Shirley Weir, who was our community partner, a creator and founder of Menopause Chicks, which is I think, to my mind, one of the largest online communities delivering evidence-based information to support individuals who are struggling with menopause and providing with them evidence-based information. So here's a bit about what we did, and Cynthia was our study coordinator who really oversaw the methodology of the study. So anyone who was living in British Columbia, who was assigned female at birth, regardless of their self-reported gender, and who was between the ages of 39 and 60 at the time of the survey was eligible. And it was open to all females again, regardless of their self-reported gender. And we intended to look at, if we had a sufficient sample size, some of the differences based on cis and trans women. We used a variety of recruitment methods, as you can see on the screen here, that included social media, online, physical ads, ads in buses up in rural communities, word of mouth, media, and we ended up with a final sample of 2,133 participants who consented to participate. You can see the numbers went down there after we excluded some folks for being ineligible, and we ended up with a final sample of just over 1,500 individuals who completed the survey in full. Of that larger sample, a subset who were specifically chosen based on geographic spread across the province were selected for an in-depth qualitative interview. And for this portion of it, we had 20 participants. And so as we share the findings with you, we're going to share some of the quantitative findings and then sprinkle in some of the qualitative findings so you can have appreciation of just how some of the quantitative data come to life in the participants' stories. So as you can see, we had pretty good spread from across the province of BC. The majority did identify as cisgender women. And so I will be referring to the sample as women throughout, but please keep in mind that we did have a subset, a smaller subset of individuals who identified not as cis, but either as agender, gender diverse, non-binary, or some other gender. And we are looking at the experiences of that subset to see if their experiences differ, given that we know and it's well established that gender diverse people experience even greater levels of barrier and disparity when it comes to managing their own health. So I'm going to share some of the initial findings with a focus on quality of life, psychological symptoms, healthcare, access, paying out of pocket, and then Dr. Adshade will talk about some of the impacts to the workplace. So first of all, we know that the menopause transition, which I mentioned, can last up to 10 years in individuals. It doesn't occur in a vacuum, and many women are also navigating other health conditions at this time in their life. In our sample, we found that 41% self-reported a mental health, a significant mental health issue. 23% self-reported fibroids, 20% reported endometriosis, which, by the way, might be a product of the fact that we also recruited from existing cohorts from the chronic pelvic pain and endometriosis sample. And led by Paul Yong, we're doing some separate analyses to look at the experiences among that group, hypothesizing that they probably have worse menopause-related symptoms than those without endometriosis. Now, participants often expressed uncertainty in our study about whether their symptoms of menopause were due to the menopause transition or whether it was due to one of these other concurrent conditions. And what they shared with us is that they were more likely to attribute to their symptoms to one of these other health conditions rather than asking the question, could this be due to my menopause transition? We measured both symptoms of menopause, menopause severity using the menopause rating scale, MRS, and we also looked at the degree of bother rated with the menopause specific quality of life scale, or MenQoL. And sometimes, interestingly, women don't acknowledge symptoms until they're made aware that they're bothersome for them. In other words, there are many reports of women sort of tolerating symptoms and accepting that, well, this is just a natural phase of life, without recognizing that that degree of bother can take a toll over time and impact many different other facets of their life. Interestingly, almost 92% of our participants reported at least one symptom of menopause at a moderate to severe intensity. Sleep problems had the highest number of respondents, with 67% who rated it as moderate to severe in intensity. And in terms of the amount of bother, so that's the right-hand side of your screen, 73% reported feeling tired or worn out as being the most bothersome of their symptoms. So you can see in this small snapshot, high prevalence of symptoms and high degree of bother by our participants. And it's borne out by some of the qualitative statements. I'm just not myself. I don't like who I am. I don't like who I've become. We then looked a little bit deeper, and I want to give a huge shout out and thanks to our statistician, Sabina Dober, who relentlessly addressed all of our questions about what about this subgroup and what about that subgroup. And I'll say it's still a work in progress, answering many, many of the hypotheses we have. But one of the questions we had certainly was, were there subgroups of women who had more symptoms than other subgroups? And what we found was that yes, indeed, and this is very consistent with our understanding of social determinants of health. So we found that those individuals who lived in population densities that were relatively smaller had more menopause symptoms and more degree of bother from those symptoms. Similarly, those individuals who lived in a household with lower overall household income reported more symptoms and more degree of bother from those symptoms. Perhaps relatedly, individuals who had less than a bachelor's degree, so relatively lower level of education, had more symptoms and more degree of bother of symptoms. And those individuals who were currently working had more symptoms than those who were not working. There were some subgroups who didn't differ from each other in our study, and surprisingly, we didn't find any differences by race, but it also may have been a product of the relatively smaller samples of racial differences within our study. So continuing on, again, so just to kind of illustrate this with one of the self-report quotes, your body's not working anymore. It's not the body you recognize. You have all these aches and pains you've never had. You don't know what it is. It just happens almost overnight. So there's a lot of trying to adjust and accustom. And then there's the anxiety and depression that comes with it. Is it hormonal? Is it something more serious, brain chemistry? You get to the point you're so confused as to, well, what is this and what do I do about it? And that sentiment was repeated throughout the stories that the participants shared with us. So we looked in a bit more depth at the kind of degree of some of a handful of psychological symptoms that we know midlife women who have menopause symptoms report more often. Namely, we looked at validated measures of depression, anxiety, quality of life, and loneliness. Indeed, those were elevated. And what we also found is that those participants who had more menopause symptoms and had a higher degree of bother from those symptoms were significantly more likely to report higher rates of depression, anxiety, lower quality of life, and more reports of loneliness. And the size of those bubbles corresponds to the degree of that relationship. So the highest kind of relationship between menopause symptoms and depression. Now, we need to keep in mind that this could be a bidirectional relationship. It's also possible that those with more depression have more menopause symptoms and more degree of bother. And there's some evidence of that in the literature as well. Regardless, this is a finding that I think really deserves more attention, is this interplay between symptoms, because collectively these symptoms can have a dramatic impact on a person's overall health and well-being and quality of life. As one participant shared with us, just finding the energy to keep up with a text conversation, like going with the flow if you're actually going to meet somewhere. So it's like actually showing up, and it's like, yeah, and then it's hard to obviously too, when you start canceling on people, you just kind of drift apart. So there are not many people left in the social circle. We then looked at how many women were getting help for their symptoms. And menopause hormone therapy, or MHT, is evidence-based, gold standard treatment. For most individuals, there are some smaller subpopulations of women for whom MHT is contraindicated. But for the most part, it is safe and considered evidence-based. Within our sample, we found that over 27% who were having symptoms were receiving evidence-based and gold standard menopause hormone therapy. And this rate's actually higher than a lot of the studies that are coming out of the US. However, on the flip side, we see that 72% who were having symptoms were not receiving menopause hormone therapy. And several of our participants did share with us that they felt that there were barriers at play that were preventing them from getting this care. So they talked about having a lack of information on the long-term benefits, but also harms, perhaps a legacy of the WHI study. They talked about having experienced reluctance of their own doctors to discuss or prescribe MHT. And they described confronting misinformation online and getting conflicting information about whether menopause hormone therapy was safe or unsafe, and being confused by that. I'd like to try hormones, but I can't get near anyone who talks about that sort of possibility. And again, we heard this quite a bit in our findings. Next, we dove a little bit deeper into what some of the access issues were that women were reporting. First of all, most of our participants did have a regular healthcare provider. And when people did not have a healthcare provider, they were most likely to get care for their menopause symptoms from a walk-in clinic. So for those who did not have a regular healthcare provider, they accessed care through a walk-in clinic first, but they also went to a virtual clinic like TELUS Health. They tried to go to a doctor's office. They often went to the hospital emergency room, or they tried to get care from a community health clinic. We then asked them where they were most likely to get care for their menopause-associated symptoms, and we found that family doctors were the most frequently accessed care provider to treat their symptoms, followed by specialists, probably OBGYNs, and then nurse practitioners. But the interview participants still expressed a lot of frustrations in either the delay in time or feeling like their needs were not properly addressed during their visits. After this, we dove a little bit deeper into the type of provider contacted for addressing menopause-related symptoms. We found that 43% of our participants accessed at least one extended healthcare provider to treat their symptoms, and 13% exclusively utilized extended health services, so not their primary care doctor, to address. And very interestingly, you can see this kind of ranked by the average number of symptoms. And I'll just point out that this list of providers doesn't necessarily correlate with evidence-based and gold standard care. And again, this may be a symptom, if you will, of women just trying to get care wherever they could. I think that having a really holistic care team, for women's health in general is so positive. And despite it not really occurring naturally, I've sort of built that myself. And I know that having a physiotherapist, having a massage therapist, having my naturopath, and having my counselor all kind of weave together with my medical healthcare team, that's been really key for me. And I think that's a good model moving forward. And I hope that there's more of that kind of holistic look at healthcare. So I'll be passing it off to Dr. Adshade, just a few more slides looking at healthcare access. And we were interested in looking at, for those people who had private health insurance, did this impact their relief of symptoms? You can see 80% of respondents had some private health insurance coverage, whether it was coverage they paid through for them on their own or through their employer. And on the whole, we found that 75% of respondents who sought various different healthcare providers, you can see them listed along the bottom, reported an improvement of their symptoms regardless of whether they were insured or not insured. So our participants on the whole experienced improvement in symptoms across the different healthcare providers that they saw. We looked at how much people were spending out of pocket, and you can see that those folks who had health insurance, so columns 2 and 3 here, spent significantly less than those individuals who did not have extended benefits plan. And on average, though, over the course of a year, our participants spent about $900 per year on healthcare services to address their menopause symptoms. And you can see this sort of staggered by the different healthcare professionals, with mental health professional sort of dominating the most spent on that. Because I get only 500 towards naturopathy each year, and 500 for physio as well. I mean, that's gone in 2 visits. And medication, we're paying out of pocket 50% for prescriptions. Or it's $110 for a 45-minute massage. What's that going to get me? Acupuncture is $80 for one treatment. It's great. I have $500. And finally, before I turn it over, we looked at whether some of those social determinants and also mental health symptoms impacted access to care. And what we found was that those individuals who lived in smaller population density, so more rural and remote towns, had significantly higher mental health scores. So more loneliness, more depression, more anxiety, and lower quality of life. And all of this likely intersect to impact their menopause symptoms and their access to care at the same time. So with that, I'm going to turn the table over to Dr. Adshade, who will share with us some of the health economics findings.
Wonderful. Thank you so much. Good morning, everyone. I'm delighted to be here today. I feel like this is perhaps a rare opportunity for an economist to come and speak to you. So I feel very privileged to be here, and actually it's slightly nervous. I was thinking about this morning. Okay. So women who are midlife today are quite different than midlife women from previous generations. Because of that, I want to start by giving you an introduction to midlife women workers today. A woman who's turning 55 this year was among the first generation for which women working was the norm. By the time that women graduated from high school, women were obtaining degrees at higher rates than men. And so what that means is for a 55-year-old woman today, not only is she better educated than women of previous generations, she's actually better educated than men her own age. If she had children, because of generous maternity leave benefits, it was easier for her to return to the workforce while her children were still small. And so this woman's accumulated decades of on-the-job training and work experience. Despite all this, if she loses her job, she's far less likely to find a new one than any other category of worker. Intersectional discrimination against older women workers is a very, very real phenomenon. At the same time, because her mother had fewer children, women in this age group have a much higher burden of caregiving for their aging parents. And because she had her own children later in life, she's far more likely to reach menopause while still having young children to take care of. And many of us are learning that even when those children reach their 20s, they're still often living in our houses and are still under our care. So I say this to emphasize the importance of women, midlife women in the workforce, and the total economic health of the province, which includes the job of unpaid caregiving. Those women are making vital contributions, and we want to make sure that they can continue to make those contributions, not just for the individual women themselves, but for the health of the economy in the province as a whole. So this chart that we're looking here represents the entire workforce of BC. You can see workers broken down into 4 categories. We have men and women under the age of 40. We have men and women 40 to 65. And then right there at the bottom, we can see men and women who are still working over the age of 65. And the purpose of this chart is just to point out this is that among workers who are over the age of 40, 48% of those workers are women. And that the contribution of older women is almost as large as younger women. Older women in this province contribute a significant amount to the aggregate workforce. Next, please. So the HERC study looked at the relationship between menopause symptoms and workplace experiences. So on this chart, and it's actually cut off a little bit there. The vertical axis measures the average level of menopause symptoms, the symptoms that was discussed by Dr. Brotto a few moments ago. And then on the horizontal axis, we see some of the experiences that of women in the workforce that we see in the study. So for example, if we look at the first 2 points, we can see that among women who declined a promotion, the average menopause symptom score was 22 compared to women who did not decline a promotion in which the average score was 15. So this suggests that women who have higher menopause symptoms are more likely to decline promotions. Okay, so overall, 1/3 of women reported that menopause symptoms were affecting their work. 1/4 of women reported missing days of work in the last 12 months due to menopause symptoms. 17% reported that they had to cut back on their work hours because of those symptoms. And then 1 in 10 had to turn down a promotion or any other opportunity to advance their career because of those symptoms. And then of particular concern, 17 of the individuals in our sample in the last 6 months reported that they were either fired or laid off from their job due to their menopause symptoms. And that seems like a small number. It's just over 1% of our sample. But given that there are almost 700,000 women in this age group in this province, this could represent thousands of women who are losing their jobs every year for health concerns that, according to the BC Accessible Act, meet the standards of a disability and should be accommodated by their employers. Also, given that midlife is when people are promoted to positions of senior leadership, the number of women turning down promotions, quitting, or losing their jobs due to menopause symptoms could go a long way to explain why in this province women continue to be underrepresented in both political and professional leadership roles. And actually, I want to pause here and say something that I think is particularly important to you. And that is, and I'm not an expert on this, but my understanding is that in nursing in particular, senior nurses play a really important role in mentoring and training the younger nurses. And I can imagine this is also probably true for other healthcare professionals as well, that older workers are playing an important role in the ongoing education of healthcare providers. If we're losing these workers because of menopause symptoms, it doesn't just affect those workers. We're also losing an important opportunity to have the transfer of knowledge between generations of workers. I mean, like I said, you know more about this than I do, but I think this probably affects everybody who's working in the sector, in addition to affecting the quality of healthcare in the province. Next slide, please, Lori. Okay, so we saw this sentiment in the people who were interviewed in our qualitative survey. One woman said, but the big one was not being able to concentrate. The brain fog was huge because I felt so unsure of myself. And then the whole fear of making a mistake. And that's when I knew it's like, you know what? I'm taking way too long. I'm not confident in my practice. And the second woman said, I'm just tired of not feeling good. It's impacting my success at work. Thank you, Lori. Okay. Okay. So, one really encouraging piece of evidence that we see is that having access to health insurance seems to ameliorate some of the problems that women experienced in the workforce. This graph shows the share of individuals who have these workplace experiences, reduced hours, declined promotion, quit their job, or missed work, broken down between those who had employer-provided health insurance and those who had no health insurance. Employer-provided health insurance is the top bar, which is green if you can see color, and then, no health insurance is the top bar if you can, and employer-provided insurance is the bottom bar. And you can see from the top bar, for example, that 20% of those with no health insurance had to cut back on their work hours compared to 16% who had employer-provided health insurance. So if we consider all of these outcomes, women with employer-provided health insurance were less likely to reduce their work hours, less likely to decline a promotion, and less likely to quit their jobs. The only exception is women who missed work hours. And I think the likely explanation for this is that the same employers who provide health insurance also allow women to have paid missed days of work without losing their pay. So they have paid sick days. And so those women actually have more flexibility to take sick days when they need them, which is important for their health. Next slide. So, Lori spoke a few moments ago about the relationship between menopause symptoms, anxiety, depression, and loneliness. And this is important for the workplace as well. So we know now that menopause symptoms can directly affect a worker's productivity. But menopause symptoms also affect their anxiety and depression and their sense of loneliness and isolation. We have lots of evidence from other research that anxiety and depression significantly reduces worker productivity. It's a cause for absenteeism and presenteeism, which is coming into the work but not being as productive. So anxiety and depression itself reduces worker productivity. And then likewise, there's this entire emerging body of research that says that loneliness too has a big impact on people's capacity and motivation for work. So it increases job turnover, again, absenteeism and presenteeism. So what I think we're really seeing in this data is a domino effect, where we have menopause symptoms directly affecting worker productivity. That worker productivity is contributing to already increased levels of anxiety, depression, and loneliness. And so together we see this relationship where women are stuck into a loop that makes them feel increasingly hopeless, creating additional health problems, and again, reducing their capacity for work. Next slide, please. Okay, so I spoke about the sandwich generation at the beginning of this, about the burden that midlife women are facing and how that burden is increasing over the generations. And we really see this in the data that we collected. So over half of the survey respondents said that they had caregiving responsibilities during the last year, spending an average of 25 hours per week on caregiving activities. Many midlife women are still in the weeds for raising children. 42% of the sample still had children at home. And this number actually really surprised me. I think it's because I had my children really, really early, unusually early. But 10% of the sample still has a child under the age of 5 in their home. A large proportion are providing care to an older family member or a relative. 1/3 of the sample is caring for somebody with a long-term health condition. Many women at this age group are caring for their husbands, which is something that we often don't spend a lot of time speaking about. Next slide, please. Okay, so I want to end this with this. When midlife women are healthier and more productive, this benefits everyone. We all win because we have a larger and more productive workforce, particularly when we consider the lifetime of skills and training these women bring to work with them every single day. Working to improve the health of older women will contribute positively to the health of the economy, both increasing incomes, but also increasing the tax base and making more resources available for public spending. We win because we have more women in corporate and community and political leadership. This isn't just a win for gender equality, but firms with more gender diverse leadership have been shown to be more profitable. And we know that governments with more gender diverse leadership make decisions that benefit a larger share of the population. And because organizations with more women in positions of leadership tend to promote gender diversity in all ages, we see this effect is magnified across the economy. We win when women enter retirement with sufficient savings to support themselves through their senior years. Women who leave the workforce later and earn more in their final years of life are more able to live independently in retirement. In Canada, Stats Canada has a new report that just came out a couple of months ago that says that 43% of the income of senior women in this country is paid for through government transfers, compared to only 32% of the income of senior men. And even with government transfers, senior women live on 70% of the income of senior men. If we can help women stay in the workforce longer, if we can help them advance their careers, that's going to help address the high poverty rate of senior women in Canada. And then finally, we win when everyone's well enough to contribute to caregiving for our children, for our grandchildren, for our parents, and for other members of the family. Family social support is incredibly important in this country, and when we can't do it, people don't receive that care, or people become dependent on public resources for that care. So that's mostly what I wanted to say. I just want to make, I think my main point is that we have important roles to play, and that if we can support women's health through menopause, we all stand to benefit from that. Thank you. Sorry, I should do a segue here. Sorry. Kerstin is going to speak about the recommendations that come out of the report.
Good morning. Thanks for the lovely presentations, and thanks to the WHRI for having me participate, and Dr. Brotto. So I'm going to turn things around just a little bit and spend 5 minutes talking about what we're going to do going forward. I think everybody here's the really disappointing results of this study and how poorly women feel about their menopause care. And this is unfortunately in line with data that's been published elsewhere, in keeping with results from other reports. It's also coming on the heels of 20 years of both women and healthcare providers being relatively uninformed about menopause. I think this highlights the importance of continuing to move forward, and that will include public awareness, improving knowledge among caregivers, and improving the state of women in the workplace. So I'll talk a little bit about things that are being done and can be done. So public health campaigns are really important. I think when women are aware of what's going on, they do tend to take the bull by the horns and move forward. There's actually some newer initiatives that are really exciting and bringing menopause, evidence-based care of menopause to the forefront. There's recently development of a menopause foundation in Canada, and you can find them at menopausefoundationcanada.ca. They've authored a national report on menopause where some of our background data came from, and they're really moving to increase awareness about menopause in the community. We're partnered on this project with Shirley Weir, who has a Facebook group called Menopause Chicks, which has over 2 million subscribers. And she shares evidence-based menopause about medicine and about menopause, and takes questions from the community and really engages women. The Menopause Society, so that used to be called the North American Menopause Society, or NAMS, has put out a menopause guidebook that's available to the public. And there's other evidence-based websites like mymenoplan.org, where the public can go and read evidence-based information and learn about their menopause and really start to take charge. The Menopause Foundation has a symptom tracker that people can use. My Menoplan allows people to enter a variety of symptoms and see what supports are available for managing those. So I think we're really starting to put menopause out into the general public and not have it be a dark secret. There's multidisciplinary projects that are also underway. I'm most proud to be part of the development of the Complex Menopause Clinic and the Menopause and Midlife Health Program at BC Women's Hospital. This will be a provincial program. We'll be providing direct patient care for patients who have more complicated medical and social histories who are needing care during menopause. Also putting some existing programs at BC Women's under an umbrella of midlife care, and also starting to formalize education for learners at all levels. There's some more global initiatives that are happening. The Menopause Society has put together something called the MQ6, which is a short questionnaire and a treatment algorithm that's directed on one side to patients so they can start asking questions about their menopausal symptoms, and on the other hand to care providers, giving them a care algorithm for menopausal women to take some of the mystery out of managing menopause. The Specialist Services Committee is funding a number of different community initiatives that are putting together shared care between family doctors and specialists to help promote menopause awareness in the community. And the BC Women's Health Foundation is really putting forward a lot of support for the joint initiatives and the Midlife Health Program. In the workplace, there's really been a push. You can see that the Menopause Foundation of Canada has put together a playbook for employers. There's now a World Menopause and Work Day. So this is really, really becoming something that's globally recognized. The Menopause Society has a Making Menopause Work employer guide. So employers can start to get involved in managing care for their menopausal work employees, and women can start to understand that this is not only their personal burden to bear, and it's a shared responsibility with their employers. Finally, I think what we can really do going forward is start to advocate for formal recognition of menopause in the workplace. So there are some global consensus recommendations, and workplaces can now be designated as menopause friendly. But if we follow the lead of the UK, they've actually got a government formal response and a policy paper on menopause in the workplace. And I think that's something we can really aspire to going forward. So this is, one small step for womankind, but I think we can turn it into really bigger things going forward. And I'm happy to be involved.
And with that, we can probably open it up to any questions that people have.
Maybe to start us off, I did see a question in the chat, and that's from Emily. She's asking, she thanks everybody for a really interesting talk, but she was wondering, was the amount of exercise asked in this study and investigated as a correlate of menopause symptoms? She's wondering if it may be a means of buffering the symptom severity, especially mental health related.
Yeah, good, great question. We have not looked at that. What we've presented to you today was sort of our the main focus of what we were looking at in terms of degree of symptom burden and then impact on the workplace. But it was what started out as a very, very small focused project on just looking at symptoms. We used it really as an opportunity to look at many different facets of midlife women's health that would allow us to answer quite a few questions. And so stay tuned. We've got a long list of papers that will be emerging from these findings. And as Dr. Gustafson points out, there are other research groups that are looking at. We know that in the mental health literature that exercise is considered part of frontline care, and there's very, very strong evidence in favor of exercise as a way of not only preventing depression recurrence, but managing symptoms of depression. And so the hypothesis would be, given the increase that we see in some of those symptoms with midlife women, could exercise also be used not just to address those symptoms, but also to help with other symptoms that they may have. So it's we're excitedly watching all of the research in this area to emerge over the next few years.
There's another question from the chat asking about how you selected participants to complete the qualitative interview portion.
Right. Yes. I glossed over that relatively quickly. So unlike the quantitative phase, which was, as long as people met our inclusion criteria, they were eligible to participate. We did do some purposive advertising in those rural and remote communities. We had bus ads up in the north advertising for the HERC study. But then for the qualitative in-depth interviews, we selected participants based on racial differences and also geographic differences. And that was somewhat based on our hypothesis that those individuals who were non-white and who were living in more geographically remote areas might have a different experience of their symptoms and also healthcare access and probably impact on the workplace as well. So we use more purposive sampling for the qualitative phase. And I just want to give a shout out and thanks to both Cynthia and Julia for doing those interviews and the really comprehensive analyses of those interviews that allowed us to extract meaning from the stories that women shared with us.
Any other questions from the audience? You can either pop it into the chat or just unmute yourself and ask away.
Maybe while folks are thinking of their questions, I can use this opportunity to let people know about some of the follow-up that we're undertaking with our team. We were able to secure 2 Michael Smith Health Research BC grants, one a convening and collaborating grant and one a REACH grant that will allow us to convene stakeholders interested in the topic to really look at, what additional questions should we be looking at, especially as we build out the complex menopause program at BC Women's Hospital. And then the REACH the REACH grant is really designed to how do we disseminate these findings to those populations who really stand to benefit most. And so we've got targeted ways of disseminating the information over the coming year and really excited to continue on with some of the knowledge mobilization thanks to some of the funding that's come through.
Dr. Nicole has a great question. He asked, apart from hypertension, did you look at prevalence of other cardiovascular diseases?
That's a really good question. We did ask our participants to self-report other health conditions, and I presented it to you on that very, very first slide, looking at it by prevalence. But we did not, what I didn't show on the slide was the prevalence of specific cardiovascular disease. So that's one of the things, of course, that we're going to look at in more detail. I should also say that, this is quite a comprehensive data set that we have, and we would be very open to partnership with people who have specific research questions. And if you do have specific research questions, feel free, you can reach out to me personally or to anyone on the team. We do have a bit of a process for formulating your question and what variables you want to look at, but we really very much want this data set to be available so we can learn as much as possible about this population of women.
Any other questions in the last couple minutes here? Okay, well, if you think of any later on today, please feel free to reach out to us, Lori, or you can email us here at the WHRI, and we'll be sure to pass along any questions or feedback you have, or requests for collaboration. Gina, were you popping on to ask a question?
No, just to say amazing job. So great every time I see it. And the questions are really important because it gets us thinking too about other evaluations. So, but yeah, every time I'm so delighted to hear this work. It's a great job.
Yeah, it's interesting for sure, and always generates a lot of interest. And I see in the chat there's lots of kudos to the speakers for a great talk. So would like to thank you. So thank you for joining us, everybody. And I hope you all have an amazing day.